Good afternoon. Welcome to Medical Grand Rounds. I'm Bob Walker, Chair of the Department of Medicine. And welcome to our people here in S214 and all of you watching virtually. Today's Grand Rounds is something we've been doing pretty much every year for a while. It's called Hospital Medicine, the Year in Review. And it is two of our most treasured clinicians and teachers distilling the literature in the entire field of hospital medicine and giving it to us in an hour, which is very impressive. As you know, hospital medicine, because it's a generalist field, is a very broad domain. And so in order to be good at it, you have to keep up with literature and everything from cardiology to infectious disease to ethics and policy. There's a lot going on. So this is incredibly valuable, and we appreciate them taking the time to put it together. Our two speakers are affectionately known as the Brads. Second speaker will be Brad Monash, who's professor of medicine and pediatrics. He's also vice chief of clinical affairs for the Division of Hospital Medicine, and really a revered clinician, teacher, and leader, as is the other Brad, who will speak first, who's Brad Sharp. Brad Sharp is now a clinician educator in the Division of Hospital Medicine, was the chief of the division after I was, for many years, and really successfully took the division to new heights, won many teaching awards. Both of them actually graduated from the Stanford Faculty Development Program and teach clinical teaching to many of our trainees and faculty. So thrilled to have both of them and look forward to hearing about the year in hospital medicine.
All right, thank you. Make sure the microphone is working. People in here hear me okay? Fantastic. All right, welcome and thank you so much. Thank you so much, Bob. Brad and I are incredibly excited to be here to present the year in review in hospital medicine. We want to make sure this next hour, 45 minutes, is high yield, useful, engaging, and interesting for all of you. Again, thank you so much for the invitation to be here. I'm going to start with a reflection, actually. And the reflection is this. If you're anything like Brad and I, somewhere in your world, there is a stack of unread journals. Now, for some of you, it's an actual stack of journals, right? It's so you can picture it. For me, it's actually tables of contents that I get sent to me, but there's unread literature. And every time I see that stack or see those emails, I feel bad. Because I feel like I am not upholding my professional responsibility. I should be keeping up to date on the literature. But let's be clear, that stack of journals has some competition. I'm just going to go through a few things that compete with keeping up to date on the literature. For example, you just want to watch a movie, or you just want to watch Netflix or something else. Perhaps you're a sports fan, whether it's the 49ers or it's local college football or women's soccer. Maybe you want to take your kids trick-or-treating, or maybe regardless of your politics, you're gripped by the last 7 days before the election, or maybe you just want to spend time with your loved ones. So we have two daughters, they're 12 and 10. And I will share with you, maybe not every day, but most days, playing Monopoly with them is better than JAMA. That's just true. It is just so that is to say this is hard, but that's why Brad and I are here, to provide a literature update, as Bob said, in the field of hospital medicine. So we do this every year, so it's contemporaneous. So the literature review goes up to September. It goes up to just a few weeks ago. The process of article selection, we review 40 different journals. We scour the literature for articles most relevant to hospital medicine. The two of us and other hospitalists at other institutions then review the literature. We decided we're not going to talk about COVID. We're in a different COVID era. We did all that. We still had about 50 articles left. So then we said, well, we want this to be high yield and useful for hospital medicine providers, outpatient providers, the nephrologist, ID, everyone involved. So we said, listen, we're going to pick articles that are going to do two things. Either it's going to change your practice or teaching. You're going to do something different today, tomorrow, next week, or it's going to confirm it. You're going to say, oh, I'm doing that already. Now I know there's literature to support that. But let me be clear. The literature is for those who are providing care in the hospital, house staff, fellows, attendings, but it is for the outpatient providers who don't do any inpatient. This is for the subspecialists. We tried to pick articles for everyone. We also try to pick articles that maybe didn't get any press. We try not to all just choose the New England Journal of Medicine. So you'll see a lot of the articles are from lesser journals, but we think they're quite relevant and can impact your. We hope not to use any of the following words: There it is. Okay, so those, I don't know what any of those mean. I'm going to be honest with you. I apologize to the researchers, of which there are many very famous researchers. We are not researchers, we're clinician educators. We will talk about the methods of the studies, but we really wanted to cover as many articles as we could in the next hour or so. We'll cover about 12 or 13 total articles. Lastly, to make this engaging for those of you that are here, we are going to follow a couple patients through the hospital, and we will be using multiple choice questions. Now, we don't actually have an A, B, C, D, but I'm going to ask for a show of hands here in the room. For those of you joining virtually, I will tell you, you will get more out of this if you actually commit to an answer. So I would encourage you, if you're watching, to write down an answer. If you think it's B, write down it's B. If you think it's D, write down it's D. For those watching this down the line, I would encourage you to do the same. That is for your benefit, that we know as test takers in our lives, that if you get the right answer, you're more likely to remember something. If you get the wrong answer, you're more likely to remember something. So again, want to keep this interesting and engaging. Lastly, for those that are teachers, please email me directly and I will send you the actual slides. Their PDFs are often available, but I will send you the actual slides so you can use for your purposes, because ultimately our goal is to improve the care of patients who are in the hospital. With that, we're going to get to our first case. So to imagine after finishing a vacation, you're excited to come to work to see some patients. Now, I want you have to picture yourself as a teaching attending. So you're on the teaching service, working with trainees. You're on the first day, you're hearing about a new admission from Brittany, who's one of the interns on the team. You're gonna hear from Brittany and Melissa and Albert and some other team members. She presents the following to you. She says, this is a 57-year-old man with hypertension, alcohol use, and COPD, who presented with 2 days of abdominal pain, nausea, and vomiting. She goes on, he's afebrile, tachycardic, normal O2 stats. He has mid-epigastric tenderness on exam. Right? We have a little bit of data here. White counts 12,500, creatinine 1.3, up from a baseline of 0.8. His lipase is 893, which is high, which is quite elevated. She says, okay, I think this is acute pancreatitis, likely from his alcohol use. Great. She says, I know we've been giving less fluid lately for pancreatitis, so he's getting normal saline at 100 milliliters per hour. She says, we're giving less fluid. I said, okay. You say the following, well, you were right after the waterfall trial. You may be familiar with a few years ago, we are giving less fluid for acute pancreatitis. Here is my question for the team. Which fluid should we be giving? Specifically, should we use NS or LR for acute pancreatitis? How does the team respond to your question about fluid choice patients with acute pancreatitis? Here you're for me to give you 4 choices, and I'll have you vote. Is that Brittany says, ooh, I was always taught to use NS. We use normal saline, right? Melissa's the other intern says, I don't think it matters. We just have to give them fluid, right? And then Malik, who's the medical student, is like, well, it's really interesting that actually I found a paper actually from last January that showed we probably should be using LR. He pulls out his iPad and shows you all this paper entitled Comparison of Fluid Resuscitation with LR versus normal saline in acute pancreatitis, an updated meta-analysis. You're like, oh, wow, that looks like a good article. And Albert, who's the resident on the team, Albert's having a rough week. Yeah, Albert's like, duh, that's easy. NS all the way. LR is for surgeons. All right, who says A? We're going to go with normal saline. All right, who says B? Just have to give fluid. C, who's going with Malik? All right, looks like 80% of the room in here. And then D, is LR for surgeons? That's okay. The answer is no. The answer is no. This first article, published in January, tries to answer this question of what is the optimal fluid in patients with acute pancreatitis, right? The cornerstone of management in pancreatitis, fluid, pain management. But the question is there a difference specifically between lactated ringers and normal saline? This is a meta-analysis of randomized controlled trials and observational studies. So some randomized controlled trials, observational studies, comparing NS to LR in acute pancreatitis. The observational studies, they controlled for confounders. Now, I will say most of these studies were before the waterfall trial, so they had different amounts of fluid, but they controlled for that as well. Quite simply, they wanted to say, in acute pancreatitis, does fluid choice matter? So total of 5 randomized controlled trials, 4 observational studies, about 1,400 patients. These are typical pancreatitis patients, mainly alcohol and gallstone pancreatitis. Here are the outcomes they looked at, again, comparing LR to normal saline. They looked at development of moderate to severe disease, ICU admission, and local complications. Briefly, what are those? Moderate to severe disease is like, did the disease get worse? Did the pancreatitis get worse? Did they develop organ failure? Did they develop acute lung injury? Did it get worse? Did they have SIRS criteria? ICU admission is, did they need ICU admission? And then local complications are necrosis, abscess formation, otherwise. Comparing LR to normal saline, lactated ringers, rates of moderate to severe disease was cut in half. So the odds ratio is about 0.5, statistically significant decrease in development of moderate to severe disease. So just by the fluid choice alone. Now you may be wondering, for those following like odds ratio, okay, 0.5, so that's like 4% to 2% absolute risk. No, this is like 20% to 10%. So a huge decrease in development of moderate to severe disease. Maybe not surprising, rates of ICU admission way lower, like a 60% decrease in needing to go to the ICU. Ultimately, local complications also cut in about half, all statistically significant, clearly improved outcomes. And then there's more. Length of stay shorter by a day. Patients went home, and that was statistically significant, a day earlier. There was no difference in mortality, and then no difference in other outcomes. So there was no downside to using lactated ringers compared to normal saline. So what do we summarize? LR in the setting of acute pancreatitis associated with milder disease, less likely to go to the ICU, fewer complications, shorter length of stay, didn't change mortality, and there certainly was no downside. Now, this next line will be, what are the methods? So these were a handful, a lot of these studies were quite small, 60 patients, 72 patients. So the authors say, listen, if we want to confirm this, we should do a big randomized controlled trial. But I'm going to argue there's not that much difference between the two, and there may be a huge clinical benefit. And I love this because there is biologic plausibility. So lactated ringers, the lactate as the buffer, suppresses production of NF-kappa B, which we think drives some of the inflammation in pancreatitis. So the idea is, and normal saline doesn't do that. So the lactated ringers is actually actively suppressing inflammation. Now, for those that are plasma light fans as another balanced fluid, we just don't know. It just hasn't been studied. So it's similar balanced fluid, but we don't know if it would have the same outcomes in pancreatitis. No difference in cost. So again, before the IV fluid shortage, a bag of lactated ringers cost the hospital $1. A bag of normal saline costs the hospital $1. So essentially the cost is the same. So this is a no-brainer for me. In addition to giving less fluid in pancreatitis, I'm now going to LR in the management of pancreatitis. It may have all these clear clinical benefits and not much downside. So we're going to go with Malik here. His paper nailed it. So again, LR in the patients with acute pancreatitis. All right, the case goes on. Brittany's like, okay, we're going to change to LR. Great. She then says, oh, one thing about his labs, he got a UA, which had 11 to 20 white cells. Could he have a UTI? He didn't have any symptoms, but that seems like a lot of white cells, 11 to 20 white cells. You ask the team, do we have to worry about a UTI with 11 to 20 white cells? So changing a little bit about diagnosis of urinary tract infection. How does the team respond to your question? Do we need to worry about a UTI with 11 to 20 white cells? Brittany like, ooh, I'm worried. When it gets above 10, that seems like real to me. Melissa's like, I don't know. Pyuria is pretty common. So like, I'm not sure it's a good cutoff. Malik is like, well, it's really quite interesting. Pulls out his iPad and says, oh yeah, well, I did see this study that showed a UTI is unlikely with less than 20 white cells. And this is the paper, there it is. Performance of urinalysis parameters. I'm predicting the UTI. Does one size fit all? And then Albert, having a rough day. Albert's like, yeah, who cares? The lab will probably lose the sample anyway. I hate my job. All right, who says A? Who's going to go with, we're worried. Who's going to go with B? So Melissa, all right, who's going with Malik? Put the paper right there on his iPad. Perfect. All right, then Albert, we're going to give him a day off. It's going to be fine. All right. So I love this study. It's a short take. It's a couple slides highlighting one article. And I love this study because it's one of those things that comes up every day in the hospital. Like, how many white cells? Does it predict UTI or not? So published in Clinical Infectious Diseases just about 3 weeks ago, a multi-hospital cohort study, a big cohort, multiple hospitals, and they basically took patients in the hospital who got a UA and a urine culture. And they said, these patients had a UTI clinically, these patients did not. And then they evaluated the test characteristics of the common things we send when we send a urinalysis. What were the results? So 3,300 patients, 20% had a UTI. Again, trying to ask the question, when we look at the different parameters, what predicts presence or absence of a UTI? I'm going to focus on these three: presence or absence of leukocyte esterase, presence or absence of nitrate, and then 20 white cells as the cutoff. They focus mainly on the negative predictive value, that is the ability to say that patient doesn't have a UTI. And just to ground everyone, negative predictive value of 1 is a great test. So if the esterase is negative, the test is like 0.95. Again, not surprising, right? Because esterase is often a sign of inflammation of white cells. Nitrate, not as good, because you can have UTIs with non-nitrate producing, but still 85%. And how about that white cells of 20? That's like 0.9. So for me, it's like 90% of the time, the whites are less than 20, like, I don't think they have a UTI. So reasonable negative predictive value. Maybe not surprising when you combine them, negative nitrate, low white cells, negative esterase, low white cells. The predictive value gets even better, meaning negative predictive value. And then this is one of the key takeaways. None of them had positive predictive value. I mean, even white cells more than 20 was not consistently predictive of actually having a UTI because pyuria is so common. People have pyuria for all sorts of reasons. It doesn't actually predict presence of a UTI. So the punchline here is that the parameters in the urinalysis are good negative predictive value for esterase, nitrate, and less than 20 white cells, but poor positive predictive value as pyuria is so common. And as all the infectious disease people will tell us as generalists, this should be symptom-based, right? So we probably shouldn't be diagnosing urinary tract infections absent symptoms, but this helps me say, at those levels, I'm less worried about an actual urinary tract infection. So we're going to go with both Melissa, because pyuria is pretty common. There's not a good cutoff. And then Malik nailed it again with the second paper. All right, you're like, Malik, that's awesome. So he doesn't have a UTI. We're all good, just pancreatitis. The patient improves. And on hospital day 4, the team's working on his discharge. So flash forward 4 days, he's better. He's getting ready for discharge. Brittany's working on the discharge. Somebody says, hey, I know you're a hospitalist, but I'm wondering if we know what PCPs actually want from our discharge summaries. Do you know? Brittany asks you. You realize you haven't actually ever thought about that before. You're like, I just do the discharge summary. I haven't actually thought, what do the primary care providers actually want? And then, out of nowhere, Malik. It's like, I couldn't help it over here, but I did see this paper, which tries to answer that very question. There it is. Pulls out this paper, Primary Care Physicians' Perspectives on High Quality Discharge Summary, published in JGIM. You will notice Dr. Vimla Schwartz is the DGIM division chief at ZSFG, was one of the authors on the paper with colleagues from UC Davis. Again, I love this study because it helps. Something that happens every day here. Patients are getting discharged every day at this hospital and others, but how best can we tailor discharge summaries for our primary care providers? So semi-structured interviews, 20 primary care providers, all at UC Davis. Most had more than 10 years of experience. So they just interviewed them and said, what's an ideal discharge summary from your perspective? I'm going to list 5. There's multiple outcomes, the multiple things they measured. I'm going to list the 5 that they listed at the top. Number 1, they said, please have a clear to-do list. And this has become part of the culture here. I can tell you I've been here a long time. Go back 5 years. This is not part of our culture. But now if you get a discharge summary from this institution, you will get a to-do list. Here's an example of one. There's no PHI. I was on service a few weeks ago. This is at the top of the discharge summary, clear to-do list. So that's number 1, is I have a clear to-do, what needs to be done. Number 2, identify incidental findings. Oh, that thyroid nodule, that pulmonary nodule, the TSH that needs to be checked. That could be part of the to-do list, or it could be separate, but clearly identifying these are the things that we are hoping that the primary care provider will follow up on. 3, not only list what medications are changed, but why. That patient was on losartan for 4 years, got stopped in the hospital. Why did they change the insulin? Why are they off their empagliflozin? Whatever it might be, that to say why. If a medication was changed, the justification for why. That's both for the provider so they know, as well as for patients and family and otherwise. So listing not only medication changes, but change for this reason. 4, be clear about the duration of treatment, and specifically put dates, not just 4 more days, because when they're reading the discharge summary, that's maybe variable in time. To actually say, here's the end date, steroid end date, antibiotic end date, so listing clear dates. And the last one is, they actually don't want the day-to-day, or I call the play-by-play. That is, the primary care providers don't care how Oslerian we are in the hospital, how great our differential is. We thought about this. We thought about lupus. It's not Sjogren's. No. They don't care about that. They just want to know, what did we think it was? What happened with it in the hospital? And what's the status at discharge? Like, that's it. All that huge big paragraph from day 1. No. Don't give me the play-by-play. Just the PCPs would say, what did we think it was? What happened with it? And what's the status at discharge? So those are the 5 things. So this is I maximize the handoff from inpatient to outpatient, to-do list, incidental findings, highlighting med changes, medication timing, and then trying to be brief in our summary for the primary care providers. All right, I'm gonna keep going. Doing great on time. Brittany says, oh, that's awesome. I'm gonna refine my discharge summary. It's gonna be great. Patient gets discharged with close follow-up. Fortunately, he presents 3 weeks later with shortness of breath and cough. Number 57, alcohol use, COPD. He's febrile, and it meets SIRS criteria. He's hypoxic, quite hypoxic, on 10 liters, high flow nasal cannula. Bilateral crackles on exam, and his IVC is collapsible on POCUS. More data. His white count's 18,000, chest X-ray shows right, graded left, bilateral opacities. Brittany's like, I think this is severe community-acquired pneumonia, given the clinical presentation. She's like, okay, got antibiotics, got a few liters of fluid, He's on step down, but I'm worried he might need to go to the ICU. And you're like, oh, I'll make this a teachable moment. And I'm going to make it a teachable moment about steroids in severe community-acquired pneumonia. You ask the team, does anyone know if there is evidence to give steroids in severe community-acquired pneumonia? That's what you're asking the team. How does the team respond to your question about steroids in community-acquired pneumonia? Brittany's like, I don't think there's good enough evidence, but I'll be honest, I'm not sure. Melissa's like, yeah, but aren't we just doing that for COVID pneumonia? I didn't think we did it for other pneumonias. Maybe surprising no one. Malik's like, oh yeah, well, there was a great meta-analysis actually that just showed a mortality benefit. There it is. Corticosteroids in community-acquired pneumonia, systematic review and meta-analysis. And then, yeah, Albert's having a rough day. Albert's like, Malik, did you want to just take over as the attending? Just want to be the attending? Just like on over? Great. All right. Who says A, not enough evidence for steroids? Who says B, COVID pneumonia? Who's sticking with Malik? Who's sticking? There we go. C. All right, awesome. And then again, we're going to give Albert the day off. All right, so steroids in community-acquired pneumonia. This has been one of the classic pendulum examples in the practice of medicine. For a while, no way we're giving steroids for pneumonia. And then we started it, then we kind of stopped. I now think it's swung that this should be the standard of care for patients with severe pneumonia. And this is a paper published in JGIM last summer, systematic review, dose response meta-analysis of randomized controlled trials. So this is a analysis, systematic review, randomized controlled trials of steroids versus not in community-acquired pneumonia. It did include the Cape Cod trial for those who like named trials, which was a New England Journal of Medicine study published last year. It included that and all the other ones. And they did look at severe pneumonia versus non-severe. Now, this is a little bit of practice pattern variability because there are tables and charts of like what defines severe pneumonia. But practically, as a practical clinician, I don't find that useful in the moment. I'm like, well, if they're in the ICU, that's severe. Easy enough. If they're on their way to the ICU, that's severe. If they're on 6 liters or more, that's probably severe pneumonia. If somebody says, like, if you feel like that's severe pneumonia, they would have counted because they used port score, curve 65, and all of that. All right, so what did they show? 18 studies, 4,600 patients, been, again, randomized controlled trials, steroids versus not. 10 of the studies looked at severe pneumonia, 8 of them were non-severe. And then what's cool about the study is that the studies had different types of steroid durations, methylprednisolone, prednisone, dexamethasone, hydrochloric. They were able to say which steroid, what dose, and what duration may be optimal based on the data. So not only is it effective, but what practically should we be doing? The main outcome they looked at is mortality. I'll break it into severe pneumonia and non-severe pneumonia. So patients who had severe pneumonia who were randomized to steroids versus not, it was a nearly 40% decrease in mortality. Statistically significant, and that was about 11% to 6% roughly. So there was an absolute risk reduction, a real mortality benefit. That was not true for severe pneumonia. So this was really limited to patients who had severe pneumonia as a mortality benefit. But there were other outcome benefits as well, maybe not surprising. So there was less mechanical ventilation and ICU admission. So these are patients who are in the ED, have severe pneumonia, they get steroids, then they're less likely to need to be intubated or need to go to the ICU. Maybe shorter length of stay, there was some heterogeneity there. The only downside to giving steroids was hyperglycemia. And the measure there was, did they get more insulin? But otherwise, there was no increase in GI bleeding, no increase in other infections, mainly just hyperglycemia. And then the optimal steroid choice and dose was hydrocortisone in the 160 to 200 milligrams. And then 5 to 7 days was the optimal duration. And that is a similar dose we use in the ICU for other diseases. I'll come back to that in a minute. So steroids for pneumonia, decreased mortality in severe pneumonia, not true for non-severe pneumonia, decreased ventilation, ICU admission, maybe shorter length of stay, and hyperglycemia is the only downside. So methodologically, this is pretty convincing to me. Lots of good randomized control trials, rated this at a moderate certainty evidence in terms of and benefits with little harm. So steroids likely reduce mortality in severe pneumonia, not true in non-severe, very few other side effects. And then to make this very practical, a very typical regimen would be hydrocortisone 50 Q6 for 7 days. And a couple other practical things, you can start that intravenously when the patient's severe in the ICU, but once they're taking PO, you can switch it to PO. And again, 7 days, 5 days, some of the studies showed as well. So we're going with Malik again. It was a great meta-analysis, showed a mortality benefit. All right. Based on this, Brittany's like, oh, he's got severe pneumonia, 10 liters, high flow. We're going to give hydrocortisone. Great. Now you're rounding up the team the following day. And you notice it's really this curious thing. In each room, a folding chair has been placed right next to the bedside. Like it's like right there. You walk in the room and there's a chair right there at the bedside. And people are sitting down and chatting with the patient. You get back to the team room and you're like, hey, did anyone notice that on all of our patients we were rounding on today? There was a chair right next to the bedside. It's like crazy. How did that happen? Yeah. And then, Malik is like, well, I hope it's okay. I read this great paper last night about nudging people to sit down with patients. So I went around this morning and made sure all the chairs were sitting there for our patients so that we would sit down and talk to the patients. And you're like, oh, can I see that paper? And here's the paper, Effective Chair Placement. This is about physicians' behavior and patient satisfaction. You randomized deception trial. Love this study. All right, so here is my last short take. We'll pass it to Brad. A single center, double-blind, randomized deception study. Yeah, so deception, basically no one knew the purpose of the study except the research coordinator. So what did they do? Well, they randomized hospitalist patient encounters. So again, these were practicing hospitalist physicians. So they randomized encounters to chair at the bedside, like sitting there within 3 feet, or a chair in a closet. The control was all these rooms had a chair in the closet. They were randomized to chair next to the patient or in the closet. So the research coordinator went around in the morning, half the rooms would put the chair out, half the rooms not, and then would follow the hospitalist around and just see what happens. Hospitalists had no idea this was going on. Patients had no idea. That's the deception part. All right. And here's what it looks like. This is a picture from the BMJ. The top, that's the intervention arm. There's the chair. The bottom, here it is. People can see. There's the chair in the closet. Way over here. So far away. So far away. Okay. So what were the results? The 125 patient encounters were randomized. And the question they asked first was, did the hospitalist sit down? There's the chair right there. There it is, right there. Sitting right by the patient. Each of you thought exercise for all of you. What percent of the hospitals actually sat down? There's the chair right there. It was 60%. You're like, wow, that's pretty good, 60%. But what did the other 40% do? The chair is right there. Were they like this? So we need to talk a little bit, or is it like this? So let's talk about your discharge. But like, what are they doing with the chair? I don't know. 60% sat down, 40% did not. How about the control arm? Oh, so far away. I'd have to walk across the room, open the closet, pull out the chair, and sit down, 7%. So the odds ratio was 20, actually. 20 times more, essentially, more likely to sit down with the chair right there. Now, surprising no one, having the chair there was associated with higher, those are patient satisfaction scores, so patients are more satisfied. There was no change in actual time spent at the bedside or perception of time spent. So it's not as if the hospital is sitting down, they then spent 5 more minutes there. No, same time. And the patients perceived the same amount of time as well. And then they did this awesome thing. They're like, let's calculate a number needed to sit, actually, not a number needed to treat, a number needed to sit. So how many chairs do you have to put out for one hospitalist to sit down? One hospitalist, and it was 0.8, actually. So they only put 1.8 chairs out for one hospitalist to sit down and improve satisfaction and all of the above. All right. So what do we conclude? So methodologically, right, it's just a neat, cool little study. Yeah, chair placement associated with more sitting, improved patient satisfaction, no change in time. So just sit down. Just get you don't have to argue to pull the chair out and randomize to that, but just like go get a chair. It takes a minute, totally worth it from a patient standpoint, and you'll get a chance to sit down. All right, with that, you agree you're going to make this a shared responsibility. You're going to make sure there's a chair for people to sit down. You finish your teaching for the day. Malik's like, oh, I'll send out the teaching points. I'm good. I'll send it out. Teaching points. You get started on his letter of recommendation for residency, hoping he does medicine. So, and with that, he sends out the following. Consider using LR for acute pancreatitis instead of NS. Urinalysis, good for its negative predictive value. Think about the BCD with discharge summaries, that to-do list, incidental findings. We're going to skip the play-by-play, timing of medications. Steroids now standard of care for severe community-acquired pneumonia, and just get a chair and sit down. With that, we're now between 2 cases. I'm going to do something a bit unorthodox as we pitch to Brad. For those people here in the room and people virtually, you can do this with yourself, which is I want you to, in the room, I want you to turn to the person next to you and share one of 3 things. Share 1, something you learned in the first half hour. 2, something you're going to do differently, or something I said that you think is full of crap. You're like, yeah, I know he said it, but I'm not doing it. I'm not sitting down, whatever it might be. So take a minute to share. People in the room, people at home, I want you to reflect on one of those. Something you learned, do differently, or you don't believe, and then I'll have Brad come up for case number 2. So take to share here in the room.
Thank you, Brad. Okay, in the back? In the back row, Danielle, can you hear me back there? Great, awesome, wonderful. All right, so welcome to case 2. After an exhilarating day, working with some truly impressive trainees, you're excited to begin managing some patients on your own. Here at UCSF, we have the Goldman Medical Service. So suspend your disbelief and put yourself on as a Goldman direct care attending for the next case. You're called by the emergency department to admit a 76-year-old man, history of hypertension, who's presenting with fevers, chills, and mild confusion. He reports 2 days of abdominal pain and anorexia, recently recovered from pneumonia. Thankfully, Brad, he did get steroids for his pneumonia. Vital signs show that he's febrile, tachycardic, has a systolic of 95, and is satting well on room air, or satting a little bit low there, 92%. He's ill-appearing, confused. Lungs are clear. He has mild left lower quadrant tenderness. His neurologic exam is non-focal. White count shows 22, creatinine is 1.1, lactate is 2.4, and his chest x-ray is clear. All right. So you're going to have 2 audience response questions from me. This is the first of 2. And in general, the question is this. In general, in your approach to sepsis, in addition to fluids, what antibiotics do you prescribe? So in general, in addition to fluids, what antibiotics do you prescribe for presumed sepsis? A, Vanc and cefepime. B, Vanc and piperacillin tazobactam. C, can I say it depends? T, no antibiotics, I just consult ID in the AM. Or my personal choice, E, no antibiotics, discharge directly from the ED to severe sepsis clinic. All right, show of hands for A, who's Vanc and cefepime all the way? All right, any of us, any East Coasters? That's what we used a lot. Vanc and Zosyn, the Vizocin. All right, got some. How about it depends? A nice mixture here. Who consults ID in the morning, holds off any decision making, and who is discharged into severe sepsis clinic? Nobody's doing that yet, huh? All right. So you might not know that we have an important decision ahead of us in 2024. And I'm sorry to digress, but that important decision is cefepime versus Zosyn. All right. For the next 30 seconds, I'm going to walk us through the recent history of the battle between cefepime and Zosyn. All right, it all started with some studies popping up in the literature suggesting an increased risk of AKI with Zosyn, specifically when it was with vancomycin. So we all got panicked, said, oh no, what's going on there? But then some studies came out saying actually cefepime is worse, specifically with pneumonia and aspiration and tube feeding. Cefepime's worse. Then we saw a crop of studies saying, actually, and they're probably a wash. This was a study looking at ICU patients with pneumonia, no significant difference between the antibiotics. Then this study came out of the VA. This was a retrospective cohort study showing an increased risk of decompensated heart failure from Zosyn. Maybe the salt load was Zosyn. But then we had this study, cefepime versus pip/tazo in adults hospitalized with acute infection, the ACORN trial. So this study showed at 14 days there was no significant difference in renal function or mortality. Mic drop, or ACORN drop, if you will. It turns out if you give an acronym to a study, it increases the gravitas of the study. So all my studies moving forward are going to have really creative acronyms. So we thought case was closed, done, ACORN were completed. Let's move on to the next chapter. Then along comes this study looking at mortality of patients with sepsis administered pip/tazo versus cefepime. This is the study I'm going to share with you today. So the study investigators asked the question, in adults with sepsis, does pip/tazo increase mortality compared with cefepime? This was a retrospective cohort study of adults with sepsis during a period of national pip/tazo shortage, an ingenious study that took advantage of a national shortage to really answer a complex question. So this was done at University of Michigan, go blue. And here's what their antibiotic usage looked like. So this was an institution that really used pip/tazo predominantly. But during that period of shortage, you'll see it flipped, and they used a lot more cefepime. So they said, is there a difference in outcomes when we were using more cefepime? So there's a total of 7,500 patients admitted with sepsis. patients had to have organ dysfunction. So this was a sicker patient population, and they excluded patients with anaerobic infections. So patients with necrotizing infections, intra-abdominal infections were excluded from the analysis. They also excluded patients with CNS infections because cefepime has far superior CNS penetration compared with Zosyn. So they excluded those patients. And here's what they found, all right? This is the 90-day mortality of cefepime versus Zosyn. I'm going to give you a dramatic pause as we wait for the answer. Wait for it. All right. So 17 to 22%, that's a 5% absolute risk difference. If you calculate the number needed to harm, it's 20. So every 20 patients treated with pip/tazo led to one excess of mortality in this study. And this was irrespective of admission year. There was nothing specific about that time period that was different. Site of infection, as well as the receipt of other antibiotics, which they accounted for. So in conclusion, in sepsis, pip/tazo was associated with a 5% increased risk of 90-day mortality compared with cefepime. Now, this is a retrospective cohort study, so despite their efforts to control for confounders, there's always a risk of unmeasured confounders. This was a single center study, despite it being at the prestigious University of Michigan. And then you say, well, what do we do, Brad, with this contradictory data? What do we do with this? Like the ACORN study was a really well publicized study. The outcomes are different. Well, first of all, this was a sicker population. So in ACORN, only about 8% of the patients were in the ICU. Here, about 30% of the population. So a sicker patient population. ACORN looked at 14 days versus 90 days. So when this study group did a post hoc analysis looking at 14 days, they found no significant difference at 14 days. So the authors postulated that part of the problem here is the disruption of the anaerobes in the gut. And unnecessary anti-anaerobic coverage is what leads to bad outcomes in the long run. So maybe it takes more time to see the adverse effects of wiping out the anaerobes. So 90 days versus 14 days. And then they also accounted for the use of other antibiotics. So they excluded patients who received metronidazole, for example. A lot of the studies that show a worse outcome with cefepime didn't account for the fact that patients often get cefepime and Flagyl together for the anaerobic coverage. So it sort of has maybe made cefepime look worse in prior studies than it was because metronidazole was not accounted for. So my take home here is to consider cefepime in sepsis when anaerobic coverage is not needed. So if you don't need to cover anaerobes, don't put on anti-anaerobic coverage. All right, so the correct answer here was yes, it depends, because this was a general question about sepsis. And really, I want you to ask yourself the question, do I need to cover anaerobes or do I not need to cover anaerobes? So in this case, you are concerned about an abdominal source, so very appropriate to order vancomycin and pip/tazo. While awaiting the abdominal CT scan, his heart rate improves, but he remains febrile. You then receive the following page from your local pharmacist. Alert, positive blood cultures, strep species, please consult ID. Consult ID, and you think to yourself, do I need to consult ID for strep? You consult ID already for staph in the blood, for MDR organisms, for Cryptococcus, for Pseudomonas we talked about last year. All these infections we're consulting ID, and now it's like strep? Do we really need ID's help for strep? Really? So this next paper is going to help us answer that question, the predictors of mortality of strep bacteremia and the role of ID consultation. Study investigators asked the question, what are the predictors of mortality among patients with strep bacteremia? This was a retrospective study looking at adult patients with at least one positive blood culture for strep. They excluded contaminants. There was 861 episodes, 40% mitis, 25% pyogenic group, and almost 20% had endocarditis. So yes. So so the question is, how do you exclude contaminants without a retrospective scope? So they looked at charts and they saw where antibiotics continued or not. And I think the patients where antibiotics were discontinued, those were often considered to be contaminants. Thank you for the question. All right. So the 14-day mortality rate for all comers was 8%. And then they found a whole host of variables that were associated with increased mortality in this population. Here they are: sepsis, increased comorbidities, pneumonia, no source control in 48 hours, and then strep pyogenes species specifically. And then here are the hazard ratios for all of these. And you'll see that sepsis really falls out with being the biggest risk predictor of mortality in strep bacteremia, patients who are septic, who have organ dysfunction, who are clinically unwell. So then they said, okay, well, these are associated with increased risk of bad outcomes and mortality. What's associated with decreased risk of mortality? And there's two variables here. The first will be of no surprise to you, which is appropriate antibiotics. So appropriately covering the strep infection was associated with decreased risk of mortality. And the other one here is infectious disease consultation. The hazard ratio is about 0.28 to 0.29 for both, which translates as a 71% relative risk reduction. I love the number needed to treat. So in this case, number needed to treat was 18. So it took about 18 infectious disease consultations to save a single life. So my take home here is, if you see these bugs in your blood cultures, who are you going to call? Jen Babick, or your local infectious disease consultation. So ID consult for strep bacteremia can save lives. And people say, why is this? And infectious disease really helps us identifying source and achieving source control. Right? They don't stop until you figure out where is that infection coming from. All right, so blood cultures grow strep bovis. ID recommends abdominal CT. Some might remember bovis in the blood, cancer in the bowel. Shows you an area of thickening in his descending colon. You consult GI for a colonoscopy to evaluate. Now it's Saturday, and the GI consultant says, no problem, we'll get this on Monday. Patient continues to have abdominal pain, and you write for a standing acetaminophen and PRN oxycodone order. The following morning, the nurse pages you and says, the patient woke up seeing things, reporting circus clowns in his room overnight. Do people know that coulrophobia is a fear of clowns? And there's a whole literature on fear of clowns. Somewhere between 30 and 50% of folks have coulrophobia. Interesting, unrelated tidbit. So the nurse says, does he have schizophrenia or something? As you begin to furrow your brow in contemplation, here you are furrowing your brow in contemplation. Malik, what's going on? Malik walks by, and you're like, Malik, aren't you with Dr. Sharp? I was like, I got you back. He comes and hands you the following study. Like, thanks, Malik. The association between visual hallucinations and secondary psychosis, a systematic review and meta-analysis. So the study aim here was to actually produce the very first meta-analysis on this topic, looking at the presence of visual hallucinations in primary versus secondary psychosis. Now, this is a systematic review, meta-analysis, 14 studies, over 1,700 patients. So what is primary? Primary comes from psychiatric causes. Secondary psychoses come from drugs, medications, Parkinson's disease, dementia, or some combination of both. Patients who have a brain at risk of this and then get medications or toxins that can produce visual hallucinations. So their results were that visual hallucinations were significantly associated with secondary psychoses as opposed to primary psychoses. The odds ratio was 3. Now, it was more likely that patients had secondary psychosis when they saw inanimate objects like shades and shadows, or if they had visual hallucinations without auditory. So if you saw the clown and the clown wasn't talking, it was more likely to be secondary. Now, hallucinations were, if you looked at the causes of secondary, by and large in this study, this was most common for medication. Methamphetamines, cocaine, and cannabis were by far the biggest precipitors of psychosis. So in conclusion, visual hallucinations, as opposed to auditory, are more, they can signal secondary psychosis. Now, this is a case, there is mostly case control studies, there is moderate heterogeneity in study quality, but the take home here is to really think about visual hallucinations as a red flag to look for underlying medical causes as opposed to just ascribing it to primary psychiatric disease. So you suspect that his opioids in this case are contributing to delirium. You optimize his non-opioid regimen. You initiate delirium precautions. He's prepped for a colonoscopy on Sunday, which is completed without issue on Monday. And he's subsequently discharged home with biopsy results pending. 1 week later, the pathology from his surgery returns as mucinous adenocarcinoma. Now, the patient does not have a PCP. You're about to call him and you wonder, you said, is it okay to deliver this bad news over the phone? Is that okay? So what is your approach to providing bad news to patients after discharge or after clinic, for those of you in the ambulatory setting, what is your approach? A is I notify if I'm PCP, if I'm not the PCP, or the oncologist if I am, and ask them to disclose the news. B, I arrange a follow-up meeting with the patient to do this in person. C, I just call the patient and share the information. D, my AI assistant informs the patient on my behalf, and the AI has a tremendous amount of displayed empathy these days. And E, Brad, I'm not answering. I'm so over audience response. I refuse to raise my hand. A, who's like, I'm, PCP oncologist all the way. Okay, a few hands there. Who says this is always has to be in person? I'm arranging this in person. Okay. C, who says I call the inpatient and I share the information? All right, a smattering. D, who's using AI for these conversations? Now, E is a tough one because if you want E, you can't raise. All right, Teddy is raising his hand for E. We're in level 3 of Inception right now. Great. So this is a study that's going to help us answer this question: disclosure of bad news over the phone versus inpatient, and it's associated with psychological distress. This is a systematic review and meta-analysis. And the study investigators asked the question, does disclosing news over the phone cause distress? Now, as I shared, this is a systematic review and meta-analysis looking at observational studies and randomized controlled trials. And they looked at phone versus in-person delivery of bad news. And they explored outcomes such as patient anxiety, depression, and PTSD on follow-up surveys and questionnaires. So there's a total of 11 studies here, 4 were randomized controlled trials. It was moderate to good quality evidence in spite of the phone conversation. So in conclusion, in this study, there was no difference in psychological distress with phone versus in-person communication, no difference in patient satisfaction scores. Now, there was only 4 randomized controlled studies. This was all pre-COVID, and so there's more studies coming out about teleconferencing. This was before sort of video conferencing was more popular and more prevalent. So TBD, the impact of video conferencing, and also the communication had to happen with patients. So it's unclear what the impact is of speaking with families. But the take home here is that modality might not be critical. And why is this important? Because I think a lot of us harbor a lot of moral distress, distress when we're having to call and provide bad news over the phone. I know it sits with us. We think about how we can deliver this. How did that land when we hang up the phone? And so, of course, in person is absolutely wonderful when it's practical, when it's pragmatic, when we can do it. But sometimes, due to the proximity, geographic location, timing, sometimes we do have to deliver news over the phone. And I think I found this study somewhat reassuring. Of note, everyone who participated in these studies had some degree of communication training, something to be aware of. But the take home here is really think about how news is delivered, what is the script, how are we empathizing with patients and sharing the information as opposed to the modality itself. I saw a hand over here.
Well, I realize especially if you have a PCP that has PCP in the audience, it can actually be quite stressful if the patient needs disclosed information. You're trying to figure out, does the patient know, do they not know? What's my responsibility? What's already happened? And so I would ask, don't withhold information and pick up these space and stand by term message.
I'll repeat that for those virtually. Thank you. So Dr. Berman, speaking just as a PCP, said it can be really, really challenging when you are seeing a patient in follow-up and you don't know what's been communicated, what has and what has not. And so I think the importance of, if we've identified something, to share that information and then to document and or let the PCP know specifically what has been discussed with the patient. So thank you for that perspective. So I said, either one of these are fine. Notifying the PCP and oncologist, ask them to disclose the news. Of course, arranging a follow-up if it's practical is wonderful. But I found this really helpful to know that it's okay to call the patient and deliver the news with empathy. All right, so you inform the patient of the results and you put in a referral for oncology. And the patient thanks you for your compassionate care. Before hanging up the phone, the patient drops a few F-bombs. And bewildered, you're like, what's going on here? Are you okay? The patient responds, yeah, I'm just treating my pain. And you think to yourself, treating your pain with swear words? What's going on there? And what's going on? So just then, the following paper is slipped under your desk, once again by Malik, Malik's final present for the day. Here it is: Swearing as a Response to Pain, Assessing Hypoalgesic Effects of Novel Swear Words. All right, this is the final paper of the day. Study aim was to assess the impact of actual versus novel swear words on pain threshold and tolerance. The methods, they took 92 healthy patients, all English speaking, mean age was 28 years old, and they did a cold pressor trial times 4. So that's basically the patient's arm was shoved into a bucket of ice cold water. They measured patients' biometrics, heart rate, pain threshold, and tolerance. So pain threshold is when the patient said, ow, 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 this hurts. And tolerance is when the patient ripped their hand out of the bucket and said, I can't take this anymore. For each one of these 4 plunges, the patient needed to utter either a neutral word, which was a description of the table. That was a neutral word. The F-bomb, fouch, which was thought to basically mirror the F-bomb in a way, and then twist pipe, because the author said, well, maybe it's the humorous side of swearing that is leading to improved pain. And so let's just see if a funny word like twist pipe. Now, these words were designed by a panel of experts, which included a lexicologist and a scientist with expertise in swearing. So for each plunge, the participant needed to say one of these words every 3 seconds until they rip their arm out, essentially. All right, so here's the study results. What you will see is the F-bomb, fouch, twist pipe, and neutral, and you're gonna see bar graphs. And the bar graphs are gonna show you the pain threshold and tolerance. So taller bars, higher threshold, higher tolerance. Here's the result. So here, the F-bomb had statistically significant higher pain threshold, as well as significant pain tolerance compared with fouch, twist pipe, and neutral words. So in conclusion, swearing, specifically the F-bomb in this study, increases pain threshold and tolerance. Made up swear words are not as effective as the F-bomb itself. Now, this study was done in the Keele Swear Lab in the UK. Generalizability of these results is uncertain. So in summary here, consider whether anaerobic coverage, pip/tazo, is needed when you're empirically treating sepsis. Consider consulting ID for strep bacteremia. Consider that visual hallucinations may signal secondary as opposed to primary psychosis. Consider that breaking bad news over the phone might not cause more psychological distress in your patients. And then consider the analgesic properties of swearing. Here we're, as one more reminder of the take-homes from Malik, using LR for acute pancreatitis. Your analysis can help to rule out UTI. Think about the PCP with your discharge summaries. Don't forget steroids for severe community-acquired pneumonia, and just get that chair and sit down. Thank you so much.
That was fabulous. Thank you. A huge amount of ground to cover. We have about 5 minutes. Let me just start with consider anaerobes when Zosyn versus cefepime. You gave the example of it might be a belly source. Any other examples that cause you to consider that?
So in this study specifically, they excluded necrotizing infections and then intra-abdominal infections being the primary ones. I suppose if you see pus or empyema would be another situation where you want to consider anaerobes.
Okay. And Brad, these days to get hospitalized with pneumonia, you got to be pretty sick. So as you are interpreting this study in your day-to-day practice, is it pretty much everybody's now getting steroids if you're sick enough to be in the hospital, or not quite?
Thank you, Bob. Good question about pneumonia. Not quite, actually. But like I said, the criteria were elevated port score, curb 65 score. So in our environment here at this hospital, if you're on step down, you're probably in the severe pneumonia. So the floor patient on 2 to 3 liters, that's someone who would have been in the non-severe for whom there was not a mortality benefit. But again, some of this is subjective. So more and more people are getting it. I'd be curious what the ICU providers are doing in the ICU, but not quite everyone.
All right, the questions out there? Yeah.
It's the personal experience. Some time ago, I went with my wife to get the result of a mammogram. It was going to be delivered in person. So we went to the women's clinic, at which point a lady doctor came forward, addressed my wife and myself and said, "Would you follow us?" We followed them down the hallway, in an elevator, down 1 floor to a private conference room where we were informed that the test was normal. So I think this was done in the interest of privacy. I'm not exactly sure, but that sort of interfered with our feelings about it. We would have been much happier if we were told we could just go home. Everything's fine.
Right. Right. Any reaction to that?
Must have been the longest walk of your life. No, I share this anecdote with trainees, and that I'm med peds trained, and my very first rotation was in the neonatal ICU. And there was a set of twins that were born. There were 34 weekers, and we used to just intubate and give surfactant to all these kids, and they did fine. 34 weeks, they did fine, but it was common practice to do that. And so the dad said, you know, no matter what happens, wake me up. I said, no problem at all. It was like 3 a.m. I said, I'm so sorry to wake you up. Everything went fine. Kids are doing great, right? So end of story. Next morning, dad comes and says, hey, are you the one that called me last night? I said, yeah. He said, can I have a talk with you? I said, sure. He said, you're a new doctor, right? I said, yeah. He said, never start a conversation with the 2 words, I'm sorry. He said, for you, that was probably in the same breath as everything was okay. He said, I couldn't sleep the rest of the night. My heart dropped. So the story of following somebody down a corridor, going to the elevator to then find out everything is okay, that buildup for patients is real.
Yeah, absolutely. Other questions? Yeah, Brendan.
Thank you both for presenting. I have a question about the steroids, severe pneumonia. Let's say you have a case where the patient miraculously recovers, say on day 2 or 3, no longer severe off oxygen. Do you still go with the 7-day course? Because in those cases, we tend to have like a 5.
Yeah. So, question about the steroids and pneumonia. About what if the patient gets better quite quickly, which often patients with pneumonia do. It's day 2, day 3, they're down to 2 liters, 1 liter, thinking about discharge. What do you do then? Because these are randomized controlled trials, they would get a course of steroids. What I'll do in a case like that, if they're really better, then I'll match it with the antibiotic duration. I'll just do it for 5 days and say, you know what, patient's getting better, that we're going to do 5 days anyway. So again, some of that is comfort with extrapolating from the data to say that they're doing well. And part of the idea is they have less acute lung injury in that setting. They've gotten better that quickly. There's just less inflammation in there, so it may not be as efficacious in that setting, as opposed to the patient who day 4 they're still intubated, they're still on 20 liters of high flow. So I think it's a great question.
Great. Other questions? Yeah. No, go ahead.
As a mental health provider, social worker, I definitely have had a lot of conversations with patients about where they're just venting and cursing, and so we know about therapeutic value in that way. But to hear analgesic properties is interesting.
Thank you.
Thank you so much. So, comment from a gentleman in the mental health field talking about just seeing in practice the therapeutic results of swearing and seeing some study behind that is interesting.
Yeah,
so I'm much more forgiving of my children after reading.
There you go.
Studies.
Alan, did you have one?
Yeah, I just had a question about the pneumonia study again. Were COPD patients excluded from that study, or is this taken into account?
Yep. So question about the pneumonia study and the steroids. Were patients with COPD excluded? I don't, meta-analysis of multiple studies, or 18 different studies. I'll say I didn't review the table 1 and all of those, but I'll say certainly a concurrent diagnosis of COPD exacerbation, those were excluded for this reason, to say, is there a confounder there? But some percent probably had COPD. So again, you could imagine that may have been some of the benefit. Yet again, I'm a believer in when you bundle up all data from a bunch of randomized controlled trials, to me, again, this is convincing enough, especially in the setting of it's cheap, hydrocortisone is inexpensive, and the only downside was hyperglycemia, again, across 5,000 patients. So I was comforted by the lack of side effects as well.
Great. Maybe last one. I guess I'm still shocked by the ID study. And I just can't see that they found so many sources that would have been missed otherwise. And the sources required specific treatment other than the antibiotics the patients were getting for their strep infection, that explains all of it. Or were you convinced by that study?
Well, and that's why I included it, because I found it surprising as well. Strep is an organism that I feel like we got this. Mm-hmm. So definitely surprised by the results. Strep can be funky, and I think sometimes we don't always look for pus, and especially with pyogenic strep. So mitis group and you saw the pyogenes group. So I think that probably the two variables that really triggered is the importance of finding a pocket of pus for pyogenic strep. And then the other one was actually appropriate management of endocarditis. 20% of these patients ended up having endocarditis, and one could envision you treat strep bacteremia, a patient gets better, you let them go, but you're not actually treating the endocarditis.
Do you know if they drilled in to see whether the patients were getting more echoes or had more diagnosis of endocarditis or had pus drain? I'm still head scratching over that many times that they said, get a scan, somebody found pus and somebody drained the pus, and that happened, that many more times with a consult than without it?
Right. Yeah, I found the results surprising as well. As far as drilling down on what the specific behavior was and proportion, I don't recall.
And are you finding our ID consultants are welcoming all these additional consoles?
I think that we're presenting this today, so let's ask
we'll
me
find
again
out
in a year, and we'll
about a
see
week.
how this.
Right.
Yeah.
Do you want to?
I guess I would add to that, if you've seen us present before, we presented multiple studies like this that are retrospective and say ID consult versus not. The way I put this into practice is I'm like, consider. So it's not every patient, but if there's something about it that's a little complicated, that's not obvious or clear, then I'm like, oh, I probably should get someone else involved. Some cases I think are more straightforward. So my take home has always been in strep bacteremia, consider ID consult, where before I would have probably not even said that.
I can add to that, especially the pyogenes group. So strep pneumonia, for example, did not fall out. And so, yeah, I like the consider recommendation.
Great. We need to quit. Thank you so much. It was great.